Module 8, Gastrointestinal. So this recording will cover Chapter 55, Assessment of Gastrointestinal Function. So let's get started. We're going to start with a brief overview of our GI system. Now this should be a review for you because all of you have taken anatomy and physiology as well as health assessment. So the three main functions of our GI system are intake, digestion, and elimination of food and fluids. So if you are a normal healthy person with a functioning GI system from top to bottom, then you're going to take in your nutrition through your mouth. That includes food and fluids. So it goes in through the mouth, travels down the esophagus into our stomach. Now for some people who have issues chewing or swallowing or some other type of disruption in the mouth, then we can bypass the mouth and give nutrition directly to the stomach or into the small intestine. Then we go to digestion. So once that food goes down the esophagus into the stomach, it begins to be processed. And that includes breakdown with enzymes and acid, which will then enter the small intestine, which is where most of our nutrients are absorbed. From there, it's going to move into the colon or large intestine, where most of the water and electrolytes will be absorbed, where it will then be the third function, which is eliminated. So whatever the body doesn't need, has excess of, it will be excreted from the body. So now let's go over anatomy and physiology. So I will say that there's also accessory organs that work in combination with our GI system that has to be working properly in order for our GI system to be working properly. Examples of those accessory organs would be our liver, gallbladder, and pancreas, which we will eventually talk about. But if those organs aren't working for some reason, it's going to affect our GI system, so just keep that in mind. A couple of other accessory organs include the teeth, tongue, and our salivary glands. Okay, so moving on to anatomy and physiology, we have our mouth. Everybody knows what a mouth is. That is where intake happens. So if you happen to walk by a bakery and you smell the nice scents coming out of the bakery, you may start to salivate, or your stomach may tell you you're hungry and you need to eat. So that is the very first part of our GI system. Our esophagus, we're going to talk about our esophagus, stomach, and liver next. So here's an image of our esophagus. So once we eat food, we chew it up and it becomes a bolus. We swallow it and it travels down the esophagus. So we have an upper esophageal sphincter and a lower esophageal sphincter. So the upper sphincter helps to keep food down and not back out. So we don't want to regurgitate food back up. It's a one-way tube. It should all go down. And gravity also helps us process. And the third mechanism would be peristalsis. So just similar to our intestines, they have kind of like this wave-like constriction that helps to move along. Our esophagus has something similar. So our bolus will go down the esophagus, it will pass through the lower esophageal sphincter here, and then enter our stomach. So this lower esophageal sphincter is very important also because the lower you go down our esophagus into the stomach, the pH level is also dropping because our stomach is very acidic. So this lower esophageal sphincter is very important because it keeps out that acid and hopefully keeps it in the stomach so it doesn't regurgitate back up into our esophagus. Next is an image of our stomach, and this image is pretty detailed, but there's only a few things that you really need to pay attention to. So here is where our esophagus would connect, and I mentioned our lower esophageal sphincter. So the technical name is gastroesophageal sphincter because gastro, stomach, esophageal, esophagus, it's where they meet. So here's a close-up of that sphincter. So the food comes down here, that bolus, and this is where it's going to be processed. Now here's the fundus of our stomach. It's the most top portion. And if you ever insert an NG tube and you get that x-ray for verification, when you get the x-ray report back, what it will describe usually is tip of catheter in fundus. So that means it's actually in the right place because it's in the stomach and it's right at the top. So fundus is the top of our stomach. So there is lots of muscles because our stomach contracts as it's trying to kind of like work that food into, pretty much pulverize it into mushy, liquidy material that we can process. So again, gastroesophageal sphincter at the top, the food gets processed in here, goes down, and then we have also another sphincter here between the duodenum, which is our small intestine, and our stomach. That is the pyloric sphincter, and that will come into play when we talk about certain conditions in other chapters. So just know that there's two sphincters, one that separates the esophagus and the stomach, and one that separates the stomach and the small intestine. So the next image is from your textbook, and it depicts the phases of gastric secretion. So gastric secretion, gastric is our stomach, so it is preparing for food. It needs extra enzymes as extra secretions to help break down whatever we're taking in. So the first phase starts in the cephalic phase. Cephalic meaning head, brain, mental. So this is where we have sensory and mental input. So this is us smelling the bakery bread or looking at something that looks like appealing to us. This is going to stimulate our vagus nerve, which is cranial nerve 10, which is then going to stimulate gastric secretion. That moves us into the gastric phase where we're actually eating food. And during that phase, when we have that food in there, the fat, the carbs, this is going to stimulate acetylcholine, histamine, and gastrin, which is a hormone. Then the third phase, which is the intestinal phase, all of that food that we ate that's gotten broken down turns into what we call chyme, and that is going to stretch the duodenum. Okay, so this is the three phases of gastric secretion. Next is the liver. So this is one of our accessory organs, and we will be talking about the liver in depth in a different chapter. Here is a picture of our gallbladder and pancreas. Again, we're going to talk about this in depth in its own chapter. Small and large intestine. So on the left, we have this purple and yellow depiction of our small intestine. So here up at the top where it connects to our stomach, that's the duodenum. Then the duodenum connects to the middle section of the small intestine, which is the jejunum, which then connects to the ileum. Okay, so the small intestine can be divided into three components: the duodenum, the jejunum, and the ileum. And again, this is where most of our nutrients are absorbed. Then we have our large intestine, which we also call the colon, and this is each piece also has its own name. So here we have the cecum. That's where the large intestine connects to the small intestine or ileum. So we have our cecum, we have our ascending colon, our transverse colon, our descending colon, our sigmoid colon, our rectum, and then the anus. And again, the colon absorbs most of the water and fluid and electrolytes. So now that we've gone over our anatomy and physiology and the functions of the GI system, now let's talk about our actual GI focused assessment. So with any assessment, it's going to start with gathering data, and that is going to happen in our interview process. So in addition to all of the normal questions that we would ask, we would follow up and do a focus interview on whatever the patient is complaining about. So if the patient is complaining about constipation, then we're going to ask, focus questions on that. And if a patient is complaining about mouth pain, we're going to ask lots of questions about that. We also want to take in consideration nutrition, because that is a huge component of what our GI system is made to do, is to give us nutrition. So here your textbook has a sample of a MUST tool. It's a malnutrition universal screening tool. Pretty self-explanatory, so you can kind of read over it. It's really important that nutrition is one of our priorities, because if you remember, we don't already have what we need in our body to function. We have to consume those calories. We have to eat all of those carbohydrates and proteins and fats in order for our body to be able to not only complete its bodily functions, but to create tissue for healing and to fight infection and those kind of things. So nutrition is very important. So now we go into our focused physical assessment of our GI system, and that's going to start with inspection. We are going to look in the mouth because we know that's where our GI system starts, and you want to get a bright light, and inspect that oral cavity. We're going to look at the oral mucosa, the gums, the tongue. We're going to look at the teeth. And we also want to take in consideration the jaw strength, okay, that muscle strength, and the patient's ability to swallow. So as you can see in the picture, you can see a lot of things in the mouth. And if the patient is complaining of something specific, then you definitely want to look at that area even further. We also inspect the abdomen as part of our GI assessment. Again, this is just our eyes looking at the abdomen. We want to note any kind of color changes in the skin, lesions, scarring, any superficial vessels. We're looking at the shape and the contour. If the patient is obese or has a lot of adipose tissue, then their abdomen may be round. You don't want to confuse that with abdominal distension. And then here in the picture, you see that we use the landmark of the umbilicus, aka belly button, to divide the abdomen into 4 quadrants. It's very important that when you are documenting any findings or when you're auscultating that you keep in mind these quadrants, because that's how you're going to document. And then here in this image, you see this is even more divided into 9 quadrants. So for example, if a patient is complaining of pain kind of in the center of their chest, around their stomach area, we can say the patient has epigastric pain. Then we're going to auscultate after we have inspected. So the purpose of auscultation is to indirectly assess bowel sounds and the vascular integrity of the arteries that are in the abdomen. So here in the first picture, you can see the location of the arteries. We have the aorta, we have our bilateral renal arteries, our bilateral iliac arteries, and our bilateral femoral arteries. This may be more difficult to auscultate on patients who are larger and obese, but if you have a thinner patient, then you should be able to hear those vessels. And it's not pictured here, but our bowel sounds, remember those 4 quadrants. You should always start where our stool will, or the fecal matter will pass through the colon. So you always want to start in the right lower, right upper, move to the left upper, down to the right lower. So you're kind of following the passage of stool. And remember, the reason why we auscultate and then percuss and palpate is because we don't want to manipulate those organs. If you have a patient with hypobowel sounds and you palpate them, they may start to move around. And if you listen afterwards, they can sound hyper. So that is not true. That's not a true sound because you manipulate it. So just remember, always auscultate before you start touching the abdomen. And then here on the right side, you can see the order of percussion, and you want to do in a clockwise motion. In practice, we don't always percuss as RNs. That's usually left up to an experienced advanced practitioner, could be an NP, a PA, or a physician, but you as the RN, it's definitely within your scope of practice, but it does take a lot of practice to get good at that and to understand what you're assessing. So a little bit more about percussion. So the sound that you typically hear over intestines is tympany. The sound you hear over fluid is dullness. So a very good example would be a patient with ascites. Ascites is abdominal fluid collection. So if you ever have a patient with ascites, take the opportunity to see if you can hear those distinct sounds of tympany and dullness. So here in this picture on the top, this patient is lying flat on their back. And with gravity, the fluid has kind of, went to either side. So if you see here on the right and left sides of the abdomen, you would hear dullness. The intestines are floating in that fluid and they are kind of floating to the top. So here around the umbilicus, you should hear tympany. Here, same patient, remember the abdomen is full of fluid with ascites, so gravity is pulling the fluid down to this side. So at the bottom here, you will hear dullness, And at the top, the intestines are floating, so you should hear tympany. And then just a little bit about palpation. So the purpose of palpation is to evaluate the underlying structures. You're also assessing for pain, tenderness, and abdominal tone. So most of these organs, it's really kind of hard to feel anything unless the patient is pretty thin. If you have a patient that has a lot of tissue or abdominal fullness or adipose tissue, it's going to be difficult to feel really any of these structures under there. Usually you'll feel these structures, you'll be able to palpate them when they're enlarged. So especially if the liver is enlarged or the spleen is enlarged, that's when you're more likely to be able to palpate those structures. This is from your textbook, just palpation techniques. You can review that from your health assessment textbook if you need to. Moving on to laboratory studies. So we have a lot of different types of studies that we can run. Really depends on what we're looking at. So our CBC, our complete blood cell count, our red blood cells, our hemoglobin, and hematocrit. So those can indicate a loss of fluid volume, so hypovolemia. And the way that relates to our GI system is if we have a GI bleed. Okay, so GI bleed, we want to go directly to our hemoglobin and hematocrit and our red blood cell count. Also part of our CBC includes our white blood cell count. We all know that. That can indicate infection. And if we have a high white blood cell count, that is just one clue because that number doesn't tell us where the infection is. Then we have our basic metabolic panel, which is a BMP. Here we would focus on our electrolytes, and that's because our colon absorbs water and electrolytes. So if we have something wrong with our colon, then that can lead to imbalances. So we definitely want to check those. Our albumin levels, prealbumin levels, and our transferrin levels, that is an assessment of our nutrition status. And because our GI system, that's where we eat and absorb our nutrients, these labs are important to make sure that our GI system is functioning when it comes to nutrition. Our prothrombin time and our liver function test, these are both related to the liver. Remember, our liver is a very important accessory organ to our GI system. So if we have abnormal prothrombin time, aka bleeding times, we know that there may be something wrong with our liver because our liver produces our coagulation, our clotting factors, including prothrombin. So we want to check those and our liver function, of course, to make sure our liver is functioning properly. Then our urine. So our urine can look different. It can be brown. And if our urine is brown, it can be indicative of something wrong with our GI system, specifically actually our liver. And we will talk more about that when we talk about our liver. And then our stool. This is one of the most important assessments when we are looking at our GI system. So you can see here, Bristol stool chart. This again should be a review. Depending on what the stool looks like, can tell you a little bit about what's going on. So if a patient is complaining that their stool is hard to pass, it's very hard, they may be constipated. And it may be difficult for a patient to describe what exactly they're experiencing. So showing them a chart like this and they can just point to it can really be helpful. So if a patient has a watery stool like this, liquid, no solid pieces, something's going on in that colon because it's not absorbing the water, okay? Versus if it's very hard, clumping, for some reason, there's too much water being absorbed or the patient isn't taking in enough fluids and hydration. So again, these are just tools, and together looking at the bigger picture along with the patient's subjective complaints and in combination with your physical assessment, that is how we are able to find out what's actually going on with the patient. So next we're going to do just a brief overview on some diagnostic studies used commonly for the GI system. So the first one is ultrasound. So what's nice about the ultrasound is that it's non-invasive. The patient doesn't need to really do anything that special, and it's quick. It can be done at the bedside. So the patient may be asked to be fasting for 4 to 6 hours prior to the exam, but in a pinch, they're just going to go ahead and do the ultrasound anyways. So using a Doppler, sound waves are transmitted to whatever area they're looking at. They do use jelly, some lubricant that helps those sound waves to visualize better and to present the image. So this can look in the abdominal cavity. It looks at fluid. It can see tumors, cysts, masses. The gallbladder, the kidneys can also be looked at the same time for stones. And it can find obstruction. And this is really nice, again, because it's non-invasive. The patient doesn't need any kind of contrast dye. So ultrasounds are very common. Then we have our KUB X-ray. And X-rays are limited. It can't see much of the structures like an ultrasound does, but it can see bone, it can see pockets of air, it can see the outline of some structures. So this is also very non-invasive, fast, cheap, readily available. So this is often done as one of the first imaging before moving on to something, more invasive or more expensive. Next, we have our esophagogastroduodenoscopy, EGD for short, or it's also called an upper endoscopy. So this is when a scope with a camera at the end is inserted through the mouth, passed down the esophagus into the stomach. So at the end of the scope, there is a light, and it sometimes also has little tools that they can use. They can take a biopsy and some other stuff, which we'll talk about when we talk about stomach problems. So this takes about 30 to 60 minutes. The patient does need to be fasting. Their stomach should be empty. The patient's going to get IV sedation, and they're also going to get a spray that numbs the back of the throat. So this means when they wake up from sedation, the gag reflex may not be back yet. So we want to make sure that we don't feed them, we don't give them anything to eat or drink until we confirm that the gag reflex has returned. Next is an esophagram, aka barium swallow test. So this is done in radiology under fluoroscopy. So whenever you hear the word fluoroscopy, that means it's a live x-ray. It's not a still shot. It's not just one capture, it's a video. So the fluoroscopy is running continuously. So this one, the patient needs to drink a dye, a contrast dye, and it's called a barium sulfate. It is pretty quick. It takes about 15 to 30 minutes. Again, the patient should be NPO. We don't want any food in the stomach. And this can look at the esophagus as well as the back of the throat and the back of the mouth. So the image on the right here, you can see the barium is lit up bright white, and it can visualize any kind of narrowing of the esophagus. It can show the shape of the esophagus, if there's obstruction or strictures or pockets that shouldn't be there. It's also a very nice tool. Then we have our good old nasogastric tube. So you guys have had a lot of experience with NG tubes and foundations, so let's give a little review so brings us up to date. So it's very important that you understand why an NG tube would be used in a patient that has a GI condition. So here we have in this picture, there are different NG tubes. It can be inserted through the nose, through the mouth. It's going to go down the esophagus into the stomach. The tip of the tube might even extend into the small intestine a little bit, in intestinal area. We also have G tubes that are surgically placed directly into the stomach or directly into the small intestine. So we all know that a nasogastric tube is used for nutrition. We can instill tube feeding, but what I want you to focus on when we talk about the GI system is not so much nutrition, but we're talking about decompression. So when our GI tract is not working at the speed it should, maybe it's very, very slow, maybe it went to sleep, we don't have any peristalsis going on, then gas can start to build up in our stomach. That gas can cause the patient to become nauseated, it can cause vomiting, it can cause discomfort. If the patient has a surgical site in the stomach or small intestines, that gas buildup can put pressure on those incisions. If a patient has a lot of vomiting and maybe just their gastric secretions is making them nauseated, then an NG tube might be placed. Okay, so this NG tube is not going to be connected to tube feeding. Instead, it's going to be connected to continuous suction, intermittent suction, or to gravity. So to gravity is when you have a collection bag hooked up to the end of your NG tube. And the collection bag is actually the same thing as the bag you would see on a urinary catheter. It just hooks up to the NG tube. And you put it at the side of the bed, and gravity helps to bring that out. It's very slow, it's very gentle. It's the most gentle way to decompress a stomach. It's not the most common way though. The most common way is going to be intermittent suction. So that means you have it hooked up to the suction on the wall and it's intermittent. So it's going to suction for a small amount of time and then it's going to shut off. And then it's going to start up again and then it's going to shut off. There's also continuous suction, which is less common, but you still may see that ordered. And remember, our gastric juice as pictured here, it has water, mucus, hydrochloric acid, pepsin, intrinsic factor, and lots of electrolytes. So keep that in mind when an NG tube is placed for decompression. The patient can be losing all of those things. So we want to keep, an eye on their fluid balance and their electrolytes. So just to review here, an NG tube can be placed to prevent nausea, prevent vomiting, for gastric distension. So if a patient has surgery inside the stomach and or the intestine, we don't want pressure on those incisions because that can lead to complications. Or this tube can be used for lavage, which is to wash out the stomach. So maybe the patient overdosed on acetaminophen and it hasn't been absorbed yet, it hasn't reached the small intestine, then we can help to kind of suction that out and clean out the stomach. So just some terms here I want you to be familiar with. Bowel obstruction. So a bowel obstruction can happen anywhere in our bowels. It can be in the small intestine or it can be in the large intestine. But when you have a bowel obstruction, things will stop moving. Your body senses and you'll hear hypoactive bowel sounds after the bowel obstruction. And things are going to get stopped up. Nothing's going to move. So that's why gas and fluids can start to build up in the stomach, which is an indication for a nasogastric tube. An ileus, also called a paralytic ileus, that's when there's not an obstruction, but your bowels have just stopped working. Peristalsis has stopped. So it leads to the same thing. Gases and fluids can start to build up. Patient can be nauseous. They can vomit, especially if they're eating when they have an ileus. So an NG tube might be placed for that. If a patient has had surgery on their face and their esophagus, if they've had surgery in their stomach, then an NG tube might be placed during surgery. So one thing to remember with that, if a patient goes to surgery and then they come out of surgery with an NG tube, it's very important that you, as the RN, you don't mess with the tube. Okay, so normally if you put in an NG tube, we can manipulate it a little bit, we can troubleshoot it, we can irrigate it, we can kind of, wiggle it around. That is within our scope of practice. But when a patient comes out of surgery with an NG tube, especially because they've had an oral surgery, an esophageal surgery, stomach surgery, only the surgeon should be adjusting that tube. So if you come on your shift and you notice something's not right, it's not draining, it's not patent, it's not flushing, there hasn't been any output, you want to do your assessment and then you want to call the surgeon or you call the doctor. There are so many delicate structures in there, especially if it was placed in during surgery, so we do not touch NG tubes that were placed in surgery. All right. So again, vomiting or NG tube suction generates metabolic alkalosis, okay, because that suctioning is taking out, or that vomiting is emptying out our stomach, which is rich in hydrochloric acid, which is part of our acid-base balance in our body. So if we lose all that, we don't have that acid, we're going to go into alkalosis. Next is the colonoscopy. So the colonoscopy is very similar to our EGD or upper endoscopy, but this one is going through the rectum. So a very similar scope. It has a light and camera at the end, is inserted into the rectum, and it can visualize the entire colon all the way to the cecum where it connects to the small bowel. So very, very important diagnostic procedure. So you as the RN, you have a few responsibilities when it comes to a patient having a colonoscopy. So number one, education. So the patient is going to have to complete a bowel prep. The bowels have to be empty so that the doctor can see what he's looking at. There shouldn't be any fecal matter or stool in the colon. So the bowel prep, there's a couple of different medications that can be used. Sometimes it's Go Lightly, which is a big jug. It's an osmotic laxative. Or it can be like Miralax mixed with Gatorade. Yes, Gatorade. So whatever is ordered, it has the same effect. It's going to be, it's a laxative and it's going to clear the bowel. So we want to make sure the patient does that. Patient should stop blood thinners because we don't want any bleeding. The mucosa in the rectum and the GI tract, very sensitive, and we definitely don't want the patient to bleed. Patient needs to be NPO for 2 reasons. So they should not eat or drink anything after midnight. And the 2 reasons being is that, of course, we don't want food going into the GI tract because we need our bowels to be empty. And 2, the patient is going to be sedated. So we don't want them to vomit and to aspirate during the procedure. We also want to educate the patient that abdominal cramping is expected. Okay, again, abdominal cramping is expected after a colonoscopy. So you may want to let the patient know before they have the colonoscopy so they don't get, worried if they experience that after. And then afterwards, it's not reportable. You don't have to tell the doctor, hey, the patient's having this. It's expected. And finally, colonoscopy is an outpatient procedure. So a patient can make an appointment. It can be done in the hospital or it can be done at a surgery center outside of the hospital. And they go home the same day afterwards if it's uncomplicated. Okay, and that concludes this chapter.